I would like to congratulate Geistlich and thank for the opportunity to be here in this difficult moments for all of us. I'm speaking here from my living room in Porto Alegre. For those who doesn't know, it is a city located in the southern part of Brazil, where I live, where I do my practice, and where I teach and do research in these amazing facilities from the Federal University of Rio Grande do Sul, which is a public school. I've been teaching and learning and doing research for the last 15 years. So I'll try to put some more insights about what was being addressing in the previous presentation from Robert, which is a specific topic about immediate implantation. Robert also addressed very well the criteria that we have for immediate implants, which have been shown in the literature very high success rates when we follow this criteria in regards to the clinical tissue surrounding the teeth to be extracted, and also the tomographic criteria regarding the presence of palatal bone, apical bone, and buccal bone. But what I'm trying to address here with you is the situation where we don't have the buccal bone, where we have absence or lack of buccal bone, which is estimated to occur in more than 50% of the cases. Cases like this, where we have good clinical situations of the soft tissues. We also have most of the criteria on the palatal and the apical aspect of the tomographies, but instead we have the absence of the buccal bone. We have in the literature two consolidated treatment modalities to approach these cases, which are early implant placement with guided bone regeneration or ridge augmentation at the moment of the tooth extraction and late implant placement. What would be the advantages if we could, in the same moment of the implant placement, reconstruct the buccal defect? This would be a minimally invasive strategy with a lower number of procedures, lower morbidity, lower number of sessions, and of course, a quicker resolution. But what we have in the literature, that's the main contribution I'd like to provide during my presentation, is the literature that I scrutinized, and as far as I could retrieve from the literature, we have very scarce data regarding this approach. We have 3 case reports, we have 2 case series, and only 1 randomized controlled trial that I will bring to you in the next slides. Well, as far as I'm concerned and known about the literature, the first time this approach was suggested was by a group from Germany, led by Dr. Noelken in 2011, and this was the first time in a case series that were present in the complete loss of buccal bone wall. They restored with immediate implants and immediate professionalization and reconstruction of the defects with chips from mandibular ramus. It was the first time that a proof of principle was raised to rehabilitate fresh extraction sockets with buccal bone loss, inserting immediate implants and reconstructing the buccal bone defect at the facial aspect. And then we have, I think, the best evidence so far, published in 2016 in a randomized controlled trial comparing the immediate implantation at defects greater than 5 millimeters at the buccal wall. What they did was a comparison in an immediate group which received the immediate submerged implant with a block from the tuberosity and a connective tissue graft to a delayed group implantation where the closure, or where they performed the closure of the socket with block from the tuberosity and connective tissue graft. In summary, what they found in the 1-year report was that there were no significant differences in various of parameters in regards to tissue level and bone at the buccal aspect. For instance, here I chose to pick up a little bit of the data and changes with the proximal bone level were very similar in the immediate and in the delayed group, and very similar in regards to the stabilization of the gingival margin without significant differences between the two approaches. In a second publication, they provided data for the thickness of the buccal bone reconstructed in the immediate group and in the delayed group. And there was a clear trend to a thicker buccal bone wall in the immediate group in an average of 0.5 millimeters thicker in different times and in different points measured over the buccal wall. Considering that, and in accordance to what was said before, this is an interesting approach that I've been conducting in my clinical practice, and then we decided in my group to perform a randomized controlled trial to compare two alternatives to reconstruct the buccal bone defect in immediate implants. And this is the first report, which is submitted now to the Journal of Oral Rehabilitation, and hopefully you'll be able to read it fully in the next weeks. So what we did was a parallel design, examiner blind randomized controlled trial with 31 patients with 1 implant per patient. We included individuals that were non-smokers, systemically healthy, without signs of periodontitis, with 1 single tooth in the upper aesthetic zone indicated for extraction and with neighboring teeth, of course. These patients were screened to enter the study using CBCT images, and all criteria for immediate implantation were fulfilled, besides the presence of a buccal defect of at least 1/3 of the root. And indeed, they were very large, on average 7 to 8 millimeters apical to the coronal margin. And then all patients received extraction with minimally invasive techniques and immediate implant installation with a provisional crown. The apical position was determined as usual by the distance of 3 millimeters from the implant head to the desirable gingival margin. These individuals were then randomized and randomly distributed into 2 groups for reconstruction of the buccal defect. The first one, the use of a bios collagen with bioguide membrane, and the other group with autologous bone from the tuberosity. Let's take a look in a description manner how we perform this. This is an illustrative case of the DBBM group and membrane. As I showed you before, the tomographic scenario, the tooth extracted with minimized trauma to the soft tissues. Here we can see, after the implant was installed, the reconstruction of the buccal defect, and here a occlusal view with the implant placed, and you can see here bios collagen and the membrane in position, and the immediate post-op, and this provisional crown was followed for 6 months. And then this was our baseline moment, as I will show you in a few moments. And then after these 6 months with the provisional crown, we installed the final crown and follow then the patients for 1 year, as you can see here, the previous image and the final restoration followed after 1 year of function. And here the before and after images of this specific case. And in the other group, we conducted the technique described by Rosa in 2013, where a small block of bone from the tuberosity is removed and is inserted in the buccal defect. This is another case of our study, similar to that one, with almost complete absence of the buccal bone wall. And this is the moment of a impression that we made to measure the thickness of the ridge. And you can see the situation of the tooth to be extracted. And here the implant already positioned and describing the juxtaposition of the bone block at the buccal defect as is described in the technique. And here the before and after 12 months of function. In this first report that I will share with you, our primary outcome was the facial palatal ridge thickness measured in casts as described by Tarnow and co-workers. So we took impressions with addition silicone immediately after the crown installation, which was our baseline, as I told you, and after 1 year of function. So we measured, and then first the descriptive results that we had, that all teeth had thick gingival phenotype, was an important information for what we observed, and all extractions were due to root fracture. We had none loss of implants over the 1 year follow-up, and the patient-reported outcomes regarding aesthetics and function were very high, with an average VAS scores of 100 for both groups without differences between them. And here a table where we provide data in millimeters of the facial palatal ridge thickness that we measure in the casts. And here it is important that we measure this in 3 different points at the gingival margin, in red at 3 millimeters from the gingival margin and 6 millimeters from the free gingival margins. And we also had a measurement as a reference point in the contralateral tooth. And then you can see here the measurements at the contralateral tooth and the implant site at baseline, and then implant site 12 months later. As we expected, and we see in the literature, the whole ridge thickness at the implant site was always lower than the contralateral tooth, however, in a very small magnitude. And also, we had a very small change in millimeters of 0.1 millimeter in the gingival margin, 0.3 millimeters at the 3 millimeter point we measured, and 0.3 and 0.5 millimeters at the 6 millimeters point and reference point from the gingival margin. All of these measurements without significant differences between the 2 techniques. In terms of a percentage change, we had a very small percentage change, was below 5% in the 2 groups and without significant differences between them. We also measured the pink aesthetic score, which is an index measuring the aesthetic outcomes of the soft tissue, and we have very high indices approaching 11.5 and 10.8 in the 2 groups without significant differences. Remember that the maximum of this index is 14 points. And we also had a very stable situation in regards to healthy peri-implant tissues without significant differences between the 2 groups, with most of the implants considered healthy and with probing pocket depths under the 5 millimeter threshold. And interestingly, another patient-reported outcome that was not significant between them was pain over the 48 hours after the implant surgery, which was very low in the 2 groups. So with that, in this first report, we could conclude that BIOS collagen and BioGuide and a block of autologous bone from the tuberosity did not differ in terms of changes of the entire ridge, peri-implant clinical parameters and PROMs, and functional and aesthetic results over the short period or short-term period may be achieved with high acceptance by the patients and low morbidity after 1 single surgical act. Before I finish my presentation, I would like to put some perspectives because we need caution in the interpretation of these first results, because first, the procedures were performed by very skilled and trained professionals with a very high patient acceptance and compliance in a well-controlled patient population. These first reports are short-term of a short-term follow-up, and we will have future follow-ups, including CBCT comparisons, at least at 2 years of follow-up. With that, my final message is that rehabilitation of teeth with buccal bone defects is an emerging treatment alternative in the aesthetic zone, following principles for conducting immediate implants, and the reconstruction of the buccal bone defect with a slow resorption bone substitute seems reasonable due to its large scientific evidence and advantages. I'd like to thank you all for the attention. I had to hurry up because I had my 15 minutes right down. But of course, I'd have to thank also my partners that have some support and funding for my research and my university. Also, the Osteology Foundation have been struggling and straightforward to raise the implantology as a whole. And this is one of the opportunity I had in Rio in the hour last year. And of course, my whole team, my team of master's and PhD students, and my team of professor colleagues of the Department of Periodontology. Thank you so much for your attention.
Alex, I really would like to congratulate to this the way of the scientific basis that you still do this type of very high level of research. Really great job.
Thank you.
We don't really have much time. I only have one question. In your study, basically, you show no difference, right?
Yeah.
Which one would you have in your mouth?
Sure. That's the question I was expecting to hear. Not only in my mouth, but for my patients. Although we did not find differences in regards to patient-reported outcomes, that I was expecting to have a higher morbidity in the tuberosity technique, we didn't find any differences because really Gonzalo was the main researcher who was very well trained to the technique. So morbidity was very low for all the patients. Even then, I would rather use a substitute because there is large evidence of this substitute, as we know for a long time, as Vios collagen and myoguide membrane. So in the meanwhile, I would still prefer to use a biomaterial substitute instead of a autologous bone.
Nevertheless, you've shown that both work very well.
Yeah, sure. Thank you so much.